So welcome everybody, and I'm sure that we will find a very interesting and very unusual session. Unusual in the sense that it is dealing with a topic or an angle of practicing medicine that is not usually tapped, but it is vitally important. Our topic today is about overdiagnosis and how to prevent overdiagnosis. It's about introducing the concept itself. For me, that was a new concept where I came to learn about it in about 6 or 8 years, something like that, as a member of GIN, the Guidelines International Network. And at that time, a group from Australia, the annual conference was held in Melbourne, and there was a group talking about overdiagnosis and examples and coming up with a checklist that probably help how to identify overdiagnosis. And when you think about it, for me, that concept was something that I've noticed for so long, but I've never had it to be crystallized or articulated in this way. For example, when I graduated from the medical school, an older person with a blood pressure of 160 over systolic of 160 over 90 would be considered normal and would not need any treatment or anything. But nowadays, the same person would need to have a blood pressure of 140 over 90 or less, and if he happens to have diabetes, then it has to be even less than that. So things are changing, and the diagnostic criteria that are changing. What are the implications of doing this? I guess that we will hear from our speaker today, and we have a speaker who has spent over a decade working on overdiagnosis. Dr. or Professor Deborah Korenstein is a general internist, educator, and health services researcher. She is the director of clinical effectiveness at Memorial Sloan Kettering Cancer Center, MSKCC, in New York City, and chief of the General Medicine Service, as well as a professor of medicine at Weill Cornell Medical College. So she comes from an academic background as well. She earned her bachelor degree in mathematics from the University of Pennsylvania and her MD from Columbia University College of Physicians and Surgeons. And she has completed internship and residency in internal medicine in Boston. Her main research and educational efforts focus on avoiding overuse of medical resources and optimizing care value. And other areas of interest that she has include evidence-based medicine, determinants of high drug prices, and optimal management of conflicts of interest in medical education, research, and practice. And I think that is very interesting as well. Prior to her role in MSKCC, Dr. Korenstein was an associate program director in internal medicine, the founding director of the primary care residency program, and director of education for the Division of General Internal Medicine at the Icahn School of Medicine at Mount Sinai. She comes from an academia and managerial background. She also served as the editor-in-chief of American College of Physicians Smart Medicine, an evidence-based clinical decision support tool, and was a member and chair of the EBM Task Force and Society of Clinical Decision Medicine, SGIM, and a member of that SGIM Choosing Wisely campaign ad hoc committee. Dr. Korenstein provides clinical care as a general internist to adults who are long-term survivors of childhood cancer and to patients undergoing active cancer treatment. It's a relatively long biography, but I thought that every word in it is really important. And for our audience, I think they would appreciate the background, where you are coming from, and that you will be talking about this topic that is relevant to every clinician. So the floor is yours.
Thank you very much.
Screen. And for the audience, please write the questions, and you might write comments in the chat, but if you have important comments that you would like us to to discuss it, or you have a question, please post it in the Q&A section. And I'm looking forward for a very interesting session.
Thank you very much. I do apologize for the length of that bio. As you were saying it, I kept thinking I really should have sent you a shorter one, but I'm sorry about that.
Nice.
And it's funny that you gave the example of hypertension, because I'm going to use that in my talk.
Okay.
And just for one slide. And also I would put as an aside that my interest in conflicts of interest is a bit overlapping with that, because some of the things that I think drive testing and overdiagnosis are conflicted. You know, there are people with financial motivation who push that stuff. So I'm going to share my slides. Just give me 1 minute.
Sure.
Oops, sorry. Okay. Oh, sorry. This is always the little screen sharing thing gets in the way of. Sorry. Oh, did I just close that? All right. I'm sorry about this.
No problem at all.
The little bar at the top gets in the way of. Oh, here we go.
I think it will be the thing at the bottom. Yeah, perfect.
Yeah, but the problem is I need to switch up the. Hold on a sec. Oh, it won't go away.
From my humble experience, if you are using two screens, maybe if you disconnect the other screen, it will disappear.
Oh, I must say I do not know how to do that. What if I pause the share? Oh, wait, here we go. Okay, I think it's correct now, right?
Perfect. Yes.
Okay, sorry about that. Okay, so I'm going to talk a little bit about overdiagnosis, what it is, why it happens, and how it is part of a context of care appropriateness. Oops. So in terms of my own conflicts of interest, I have no relationships with any for-profit entities. My husband does, but he's a scientist and I don't honestly understand any of these things, so they couldn't possibly bias my presentation. Okay, so I'm going to start by defining overdiagnosis and then talking a little bit about the universe in which it lives in terms of care appropriateness. And I'm then going to go on to talk about the drivers of overdiagnosis. Why does this happen in modern healthcare? I'm really not going to talk all that much about what we can do about it, because I think that is kind of implied when you think about what drives it, but I'm happy to talk about that in the Q&A. So overdiagnosis, and I'm sure many of you have not heard this term before. It refers to the diagnosis of a health condition that, if undetected, so if we never knew about it, would never cause symptoms or harm to a patient over the course of their lifetime. So I'm going to illustrate that with an example. Overdiagnosis usually refers to cancer, but it really can be any clinical issue. And it's a problem because it subjects patients to labeling, to unnecessary treatments, and to further testing that are not, by definition, not beneficial, but do have the potential to harm the patient. So let's walk through this little illustration. So let's take a patient, let's say over here on the left that she's 60 years old. We'll just start there. I actually want to start with scenario 2. So let's say this patient does not undergo cancer screening. She is not diagnosed with cancer. She obviously doesn't get treated for cancer. She lives to be 85 and dies of heart disease. So this is kind of what would happen to her if we did nothing. But then in this scenario, we screen her for cancer. She is diagnosed with cancer and she's treated for cancer. And, you know, it's very possible that that treatment might be toxic, might have pretty substantial side effects, and could even have long-term harms to the patient. She still lives to be 85 and dies of heart disease. So by definition, this cancer that we found through screening represents overdiagnosis. It was the identification and then the subsequent treatment of a condition that didn't affect her life. Now, there are a couple of problems with this from a clinical perspective. One is we don't have the luxury of having these two scenarios in real life. So we don't know when we find a cancer whether it represents overdiagnosis. And I think that's a really, really important thing to keep in mind. You can't identify overdiagnosis in real time in a real patient. You can only really identify it kind of in retrospect, looking at a lot of data. And so that makes it just a really challenging thing to think about and to talk about. Now, it's to some extent, it's not surprising that screening for cancer in somebody like this would pick up disease that wouldn't affect the patient. We know that screening does this, and part of the reason is that screening tends to pick up more indolent disease and not more aggressive disease. And that's illustrated in this slide. So this is a definition of overdiagnosis that is specific to cancer. So it's a little bit more specific than the definition that I gave you. But if you imagine the evolution of cancer, there are different cancer behaviors in cancer populations. There are some in red here, very fast growing cancers that are very aggressive, and they tend to cause symptoms and frankly often cause death relatively quickly. At the other end of the spectrum are cancers that are completely indolent, that are never going to progress. Prostate cancer does this not uncommonly. Breast cancer does it not uncommonly, but there's a spectrum in really all cancers of aggressiveness. And then there are, some in the middle. So if you imagine screening happens at intervals. So let's say we screen, if this is the time at the beginning when the first abnormal cancer cell developed. And then imagine here in this red vertical line that we perform a screening test. And I don't, let's say arguably it's for breast cancer and we perform a mammogram. If in a person who has a very aggressive, fast growing cancer, they are going to develop symptoms, which is marked by this horizontal line, and then potentially even die before they even have a chance to be screened. And so what this means, we all have these stories of super aggressive cancers that just go so quickly. People die incredibly fast. And those things are not amenable to screening. You can't really help that by screening because they're just too aggressive. At the optimal screening cancers are really these yellow ones. So if we screen here, we can detect it before it would have caused symptoms. So if we had not done this screening test, it would have caused symptoms later. But here we can identify it earlier and treat it before it ever gets to this point. The same is true for slower growing cancers, but sometimes, they grow so slowly that by the time they would have caused symptoms, that may not be helpful to have treated it sooner. It's hard to know. But these snails that are non-progressive, we will tend to pick them up when we screen. And we tend to pick them up a lot of them, because they hang around for so long that they're just there to be found when we screen. But it doesn't help the patient to have found that because it never would have progressed to cause symptoms or death. So this is really the same thing that I showed you on the other slide, but it's just a different way of thinking about it. So it's really these rabbits that we're looking for when we screen, because those are the cancers or any condition for which we can intervene and make a difference for patients. But the tendency of screening is to pick up these slower growing things more often. And so that's why it leads to overdiagnosis. So I want to put overdiagnosis in context for you on this slide. And I know there's a lot on this slide, and I'm going to walk you through it. So if we start in the middle with problems of decisions of care delivery. So these are things for which, doctors are making the wrong decision about doing things. And I'm specifically talking here about doing too much, not doing too little. So that is also a problem. And these things exist side by side. And so I don't want to imply that everything we do is too much, although I am a little bit of a nihilist. But that's what we're talking about today, is problems of really too much care. So if we think about care delivery decision problems here, there's a really broad group of them that are referred to as low value care. And the problem with all of these things, low value care and overuse, the definitions really overlap. Low value care is generally meant to indicate care for which the benefits do not outweigh the harms. I don't love this term because the word value implies that it's all about cost. And financial burden and financial cost can be the thing that pushes something very expensive into the realm of low value. But the way I prefer to think about it is most of the time, low value care are things that just are not net beneficial to patients, where the potential harms exceed the potential benefits. And it's important to remember all the time that every single thing we do to patients has potential harms. It's very obvious when we think about that in terms of medications. I think we all recognize that medications have side effects. And so those are potential harms. Some of them have long-term complications that I think we think of as even more harmful. But diagnostic tests also have harms, one of which is overdiagnosis, but they can sometimes lead to other tests, which can have direct toxicities, things like, contrast dye from CT scans or biopsies that are any invasive test can have potential harms. Every single thing we do has potential harms. So there's this very broad group of things that are considered low value care. Within that, although I don't know, you could probably argue that overuse and low value care are the same things. Overuse really just means unnecessary care. And again, that's usually defined in terms of care for which benefits do not exceed harms, for which harms exceed benefits. The reason I made this bigger is the financial part is really not part of overuse, really. Within overuse is just overuse of treatments that is sometimes known as overtreatment. And that, that sort of has obvious meaning. Some people will use the word, will conflate overdiagnosis with the overuse of diagnostic tests, but that's not what the term overdiagnosis means. It doesn't mean you're doing unnecessary diagnostic tests. So there is no parallel term like overtreatment when you're referring to diagnostic testing. So then if we move over here to the consequences of these problems with care delivery, overdiagnosis is a big one of them. So if we provide services that aren't needed, particularly in the realm of diagnostic testing or screening, that can result in overdiagnosis for reasons that I described before. So we will pick up things that aren't important for patient health, and that is overdiagnosis. There's another related concept called over-medicalization, which refers to the idea that we turn things that aren't really medical problems into medical problems. One example of this is in women's health, there is a condition called premenstrual dysphoric disorder, which many women feel a little bit moody before they get their period, but it was turned into labeled as a diagnosis. And the real reason for that, back to my sort of interest in conflicts of interest, was because the pharmaceutical company started marketing Prozac, which is, I'm just blanked on the generic name of it, an SSRI as a treatment. They did studies in women who had symptoms before their periods, and they basically called this thing that is just sort of a normal part of life, they called it a disorder, and they started treating it with a drug. And so that's a little bit different than overdiagnosis, but it's certainly related. So we have care decision problems, we have consequences, and overdiagnosis is one of them. And then over on the other side of the slide, we have efforts to improve things. And these are terms that are also sort of thrown into this bucket very often, de-adoption or de-implementation. And what that means is just efforts to stop doing these things we were doing in the middle that we shouldn't have been doing. So if we were treating things that didn't need to be treated, if we try to de-adopt or de-implement that service, where that means that we're trying to do things that will stop people from providing that service. Choosing wisely, which some of you may have heard of, I just threw it in there because I think it's relatively well known around the world, is a specific effort that's been done, started in 2012 by the ABIM Foundation, that's the American Board of Internal Medicine's foundation arm, but it now has spread really internationally. And it represents, they created lists of things we should not be doing. So for example, in early, don't treat viral upper respiratory infections with antibiotics. That's an obvious one that many different groups, and they had specialty organizations make these recommendations. So I just mentioned that because it's something that's well known, and it's meant to be a way of spurring de-implementation and de-adoption. But this is a cycle because we have efforts to de-adopt, hopefully reductions in these things, hopefully fewer consequences. But overall, none of these efforts that we've seen for de-adoption and de-implementation have had a huge impact so far. So, overdiagnosis, I'm showing here as a consequence of low value care or overuse. But really, overdiagnosis, which really you can see from the illustration I gave before, is a consequence of all screening. Any screening can result in overdiagnosis, and much diagnostic testing, whether it's appropriate or not, can result in overdiagnosis. So I'm going to show you a similar graphic about the different terminology, but it shows it differently. So if you start here on the left, looking at a screening test. So imagine we're doing a test that is a screening test for cancer, let's say mammography. That may be recommended, and I know different countries have different recommendations about this, but I think in most countries, it's agreed that women of certain ages, maybe ages 50 to 70, do benefit from breast cancer screening. But even needed screening, for the reasons I showed you before, can result in overdiagnosis. That then, the overdiagnosis can result in other forms of overuse, so unnecessary follow-up testing or unnecessary treatment. And they're by definition unnecessary because they are treating an overdiagnosed cancer. But again, like I mentioned before, the problem is in real time, when you are taking care of that patient, you don't know that it's overdiagnosis, which makes this very tricky. Now, if that screening test was unnecessary, let's say we were screening women who were either too young to be eligible for screening or too old to benefit from screening, that screening test itself would also represent overuse. It could still result in overdiagnosis and have the same consequences. The same exact thing is true of a diagnostic test that we would do. A patient might have an indication for a chest CT for some reason. Let's say they have a persistent cough that hasn't responded to standard treatments. There's an abnormality on the chest X-ray, and it needs to be further characterized, for example. That might be an appropriate chest CT, but it still might find, let's say, an incidental finding in the adrenal gland that would represent overdiagnosis because it would never have affected the patient's life. But if that CT had been unnecessary, that would be overuse, and either way could still result in overdiagnosis. So I know I'm kind of hammering this home a bit, but the terminology is important actually for being able to talk about these things. So why does this happen? I'm going to talk about a number of drivers of overdiagnosis, and many of them also drive appropriate use. Some really are specific drivers of inappropriate services, but some really drive appropriate and inappropriate services, but all of them drive overuse. So I'm going to talk just a little bit about all these different things: public health initiatives, higher sensitivity tests, broader diagnostic thresholds, cultural factors, and then some kind of physician factors like misaligned incentives, defensive medicine, and cognitive factors. So I apologize because most examples I'm giving are from the US, and I generally try not to do that, but the US is just such a great example. There's so many great examples of overdiagnosis and even unnecessary care in the US that it's an easy place to find examples. But in the Q&A, I'm really curious, and I hope people will share examples from your own countries about how some of these things play out. So this is an example of a cartoon that was created for a national colon cancer screening initiative. And I think, colorectal cancer screening is not done in every country, but there is reasonable evidence that it prevents mortality from colorectal cancer. But these things always spur appropriate and inappropriate use because, and again, even the best diagnostic, and colon cancer really is a poster child for cancer diagnosis because of the fact that there's a pre-cancer lesion that can be removed early on and completely prevent cancer, which is not true for very many other cancers. But still, there will be people who get way too many of them. In the United States, we see all the time that patients get a follow-up. Let's say they have a colonoscopy. They'll get another screening test way too soon, much sooner than is recommended by guidelines. And particularly in the US, where screening often is performed with colonoscopy, there are really obvious harms to that. There are harms to the prep. There are harms to the procedure itself. And so there are definitely patient harms in excessive use of this. So the second category is highly sensitive tests. And, we've seen an improvement in imaging technology over the decades that is really remarkable. And so now we have the power to really get incredible visibility inside of people's bodies. And that can be a tool for helping people, but it can also be a tool for harming people, because the more sensitive the tests we get, usually the lower the specificity in terms of finding things that are really clinically important. And I have this on here as an example because, and I think this is, I hope for the rest of the world's sake, that this is a US specific thing. But there are places in the United States that market full body scans, and they're often provided as part of what are called here executive physicals, where kind of high paid executives in different kind of big companies will have these things as a benefit to them. And they will get these like a ton of just unnecessary imaging tests. And these things very often, and they market it also to the general population. So other just random rich people can pay for it and get these things done. And whenever you do, and again, whether it's in a situation like I've described, or whether it's scanning that's done for a good reason, you're likely to find other things on that scan that may not be important to the patient and will very often lead to overdiagnosis. So I'm going to give you an example from the literature about how this has happened one time with regard to thyroid cancer. Whoops. Let's see. Sorry, I am not able to advance. There we go. Whoops. So this is an example. These are numbers from the United States, but the same exact thing has happened and been documented in South Korea. But I couldn't find a good graphic for that one, so I used the US example. But this is clearly an international problem. So what this shows you is the incidence in green and mortality from, in red, thyroid cancer in the United States over decades from about 1975 to about 2010. And what's shown here with these vertical lines is different things that were happening in the broader environment at these times. So here we see around 1980, use of thyroid ultrasound, around 1990, growth in fine needle aspiration of thyroid nodules. And then in the late 1990s, increased use of imaging technologies like CT and MRI. And what you can see here in the incidence of thyroid cancer has grown really exponentially, particularly beginning in the 1990s over time as these things have rolled out. But mortality from thyroid cancer has not budged at all. And it's not the case that treatments have changed all that much. What this really suggests is that the vast majority of these cases represent overdiagnosis and certainly never would have caused death. Maybe mortality has inched up a tad. I think probably not, but certainly nowhere in proportion to the increased incidence. So there are all these people walking around saying that they are cancer survivors because they were diagnosed with thyroid cancer, and probably none of them really ever needed to have that diagnosis. So this is a similar issue, but a little bit different. So there's another issue of broadening of diagnostic thresholds. And Lubna alluded to this before when she talked about hypertension. And in the next slide, I'm going to show you an example that I think we can talk through related to hypertension. So whenever you have a diagnostic threshold for something that's kind of on a spectrum, so think about the diagnosis of hypertension or diabetes or even chronic kidney disease, there's always a balance between sensitivity and specificity. So where you decide where to create the cutoff to define something as being abnormal. So if you define, for example, hypertension as being any blood pressure over 130 over 80, you're going to catch everybody who really truly has hypertension in terms of having the disease which causes complications, because that's what we really care about with hypertension, right? We only care about blood pressure because if it's not targeted appropriately, it will cause harm later on to the patient. So if we have a low threshold, we will have very good sensitivity. So we'll pick up everybody who has a blood pressure that is high enough to put them at risk for clinical complications, but we will also catch a lot of people who would never have clinical complications. So we have lower specificity for clinically relevant hypertension. If we have a higher threshold, let's say we only call something hypertension if the blood pressure is greater than 160 over 90, which was kind of the old threshold, we may miss some people, maybe, who would go on to have complications of hypertension, but we will also not catch so many people who won't have complications. So there's always a trade-off between sensitivity and specificity. And what that means in terms of overdiagnosis is that a lower diagnostic threshold will capture more relevant disease, but it's at the expense of overdiagnosis and then possible overtreatment and harm from that overtreatment. So I'm going to show you a little graphic that illustrates this. This is from a paper that Meenal Kale, who's at Mount Sinai, and I published in BMJ a few years ago. So I know this looks busy, but I'm going to walk you through it. So this looks at screening, really. So, and we can think of this as screening for hypertension even. It doesn't have to be, I really want to make the point that this doesn't have to be about cancer. So let's assume there's no screening. So somebody lives their life, they never get their blood pressure checked. So if that happens, and then here's the point where there's clinically important disease when it reaches a certain threshold. So some people who are never screened for hypertension will come to medical attention because, for example, they'll come to an emergency room with severe headache and nausea and dizziness, and they'll be found to have hypertensive urgency. But, you know, some of them will reach that clinical threshold, or they'll have complications of hypertension like kidney disease, and it'll be found that they had hypertension. But until people reach that threshold, nobody will be diagnosed. So because of that, there'll be relatively few people diagnosed because it's only when they reach this threshold. There will be a lot of people with harm from the disease because we're not diagnosing very many people, but there will be not that many people with harm from treatment because we won't be treating anybody who doesn't really need to be treated. If we start screening people but have a high diagnostic threshold, so that's the blood pressure, defining hypertension as a blood pressure of 160 over 90 or greater, we're going to have more people diagnosed because there are going to be some people who didn't reach that threshold, which I have here in purple, who we're now going to diagnose because we're going to screen them. That means that somewhat fewer people will have harm from the disease, but some more people will have harm from treatment. And obviously the height of these different bars is completely arbitrary, like I totally made this up. But more people will have harm from treatment, but a lot fewer people will have harm from disease. And somewhere in there, there is a sweet spot where it makes sense to screen, where we're minimizing overdiagnosis, we're minimizing harm from disease, and we're minimizing harm from treatment. But over here on the right, if we go to a low diagnostic threshold, so that's calling anything over 130 over 80 hypertension, we're going to have a lot more people overdiagnosed. So a lot of people are going to get called hypertensive when they never would have had a complication. We are going to get fewer harms from disease because we'll catch everybody, but we're going to have a lot more harm from treatment when we start putting these people who don't really have high blood pressure on antihypertensives and giving them dizziness, maybe even syncope and falls and injuries and all kinds of other things. So this is just an illustration of how these different thresholds can play out in patients. So another issue with leading to overdiagnosis is that there are a number of cultural and cognitive factors that lead to more testing, and more testing will lead to overdiagnosis. So I'm going to talk about several of these. And again, you know, I am somebody who works in the United States. And so my gut instinct is very US focused. I know the literature in other countries, And I know that much of this is true, at least insofar as it's been studied, is also true in other countries. It's probably a little less true in many other countries than in the US, but still is present everywhere. So in terms of these cultural factors, which push us toward overdiagnosis, there's definitely a push toward new high-tech procedures and services. I think that's true because we have it available and people like using new toys. I think it's true because patients, certain kinds of patients in particular, will ask for these things and sort of demand them. In the United States example, at least, people are rewarded financially, or at least institutions are rewarded financially for performing these. And in some cases, individual doctors. I mean, I've always been an academic, and so that's kind of anathema to me, but certainly there are private practice situations in the United States where individual physicians are rewarded for pushing high-tech procedures and services. There's also just a sense that more is better. And I think this is really true in a lot of places. We feel that prevention is better than cure, which it very often is. And so that leads us to do more stuff. And we also, I think, as doctors, have an inclination toward doing something. It's hard as a doctor to not do something when we're faced with a person in front of us with a problem, or certainly when we're faced with like a diagnosis that's made on imaging. It's really hard to not do anything. And it's really, really hard for patients, once something's been identified as an abnormality, to not do anything. I think our culture of medical training tends to reward zebras, meaning those like rarer things. We all, physicians tend to get really excited when we see a rare disease manifest because we haven't seen it before. And I think we tend to reward in medical education looking for zebras and including rare diseases on differential diagnoses and things like that. And we tend, again, in our training environments and overall, we tend not to be criticized for overdoing it. We tend to be criticized for not doing something that somebody perceived as necessary. And I think this is particularly true for trainees. So there are a lot of cultural things in medicine that push us in this direction. And I would say that there have been a lot of efforts worldwide to change this. And I think to some extent, they've been a little bit successful, but I think that success is very spotty. And the culture really, really pushes against it hard. So it's something we need to be continuously aware of if we're going to change it. There are also cognitive factors. And this is a particular area of interest of mine. And I think the reason is these cognitive factors are interestingly both individual and cultural. So to a large extent, they vary among individual people. People just have different inclinations about these things, but they're also cultural. So the environment that we're functioning in also influences the extent to which we feel these things. And, both things are, I think, important. So some of those things, and again, some of these are US specific, like I think the first one is worst in the United States, but probably true to some extent elsewhere. In the US, we tend to practice defensive medicine because of malpractice concerns, and that can lead us to do more. I would say, though, that malpractice reform doesn't seem to change people's utilization rates. And so I would argue that a lot of doctors, I think, use this as an excuse rather. So I think it's not as much of a driver in the United States as people say it is, but it probably is somewhat of a driver. I think we as doctors are afraid of missing something. We want to do what's right for our patients. And again, I don't want to imply with any of this that doctors are intending to harm patients ever. I think the overwhelming majority of doctors want to do what's right for their patient. And when we do things that are excessive, and when we pursue things that lead to overdiagnosis or even kind of treat overdiagnosed cases, we think we're doing the right thing. We're not doing this because we know we're doing too much. And I think part of that is we're afraid of missing something. It's really uncomfortable to feel as a doctor like you might be missing something. We are also uncomfortable with uncertainty. And I think this has probably culturally across medicine gotten worse with high-tech imaging, that we feel like, we can get a picture of what's inside somebody and get an answer. And very often there's a ton of uncertainty in medicine. We deal with uncertainty all the time. We don't always think about it, but if you think about your practice, we manage uncertainty every single day with patients, but still we're uncomfortable with it. And some of us are more uncomfortable than others. I think, as I mentioned before, that there's a general cultural belief that more is better. And this, I think, is very, very cultural. So it's different in different countries, and it's different in different areas, different regions of different countries, and with certain populations of patients within different countries. But it's an issue in many places. I think also doctors have poor, and there's evidence for this, have poor numeracy and risk understanding. And I mean, I actually think the COVID pandemic was a great illustration of risk understanding in general across populations, not necessarily among doctors only, but doctors in general tend to overestimate the likelihood of disease once they suspect it, and also overestimate the accuracy of testing in terms of finding real disease that's important. And that's can be an important driver. But I think, COVID showed us that people have very interesting takes on their risks and culture and countries with regard to like what risk they're willing to undertake in their day-to-day lives. And it's just, I think, part of the human condition that we're not great at that. And all of these biases, though, they work together to make us overestimate the effectiveness and the just helpfulness of diagnosing and treating different conditions. And all of that leads to overdiagnosis. So, this talk, I apologize, because this talk was supposed to be one of 3 talks, and one of them was really going to be all about why we care about this. So I'm really happy to talk about that in the Q&A, but, to put it briefly, the reason we care is that overdiagnosis really leads to a lot of unnecessary stuff for patients and a lot of labeling, of telling people they have diseases that aren't important for them to know about and think about. And it changes people's self-perception sometimes to think of themselves as a person with this disease. And it's just not good for people's lives. So in summary, overdiagnosis represents the identification of disorders or diseases or conditions which will never go on to harm the patient. And it results from both appropriate and inappropriate testing. Anything that promotes test utilization will lead to more overdiagnosis. And so what that means is, even if we only did, but I shouldn't say this means that, but even if we only did the most appropriate tests, we would always have some overdiagnosis. And so it's something we always need to be aware of as a downstream result of testing. And there are multiple driving factors that include the growth in high-tech imaging availability and the broadening of diagnostic criteria. So I am going to stop there. I'm going to stop sharing my slides. And I hope that there are questions and comments.
Well, thank you very much for this very clear, informative presentation. I liked it and I enjoyed it very much. I like the examples that you have used. I mean, talking about screening for cancer, especially the breast cancer, is music to my ears, because I've been going through discussions with so many people about this. And not many people are convinced that mammography doesn't change the outcome of the society of women who are screened versus those who are not screened. And what I'm thinking is that evidence-based diagnostics does not feature very well in medical education. I don't know how is the situation in the US, but definitely here we don't teach them that. They don't find it in the whatever resources they refer to. So they don't think in terms of the sensitivity and specificity of any diagnostic tests. So that's something that probably we need to focus more and more. And as the movement of preventing overdiagnosis would go on, I think this part will evolve as well. For example, I'll share one thing and then I'll look. I think there is one question. I had a patient 2 weeks ago who had a huge mass in the abdomen. He had an ultrasound done, and the ultrasound report was normal, so there's nothing. But he had a huge hepatomegaly that you can't miss it. I had an intern, and he will say, "I can feel it. This is a very big." So, and then I told before I examined him. I told him that the ultrasound report is normal. He said, "I don't know, but I don't feel normal." And then I examined him because I haven't seen him before. And then we discovered that he has this huge mass. And when I checked the literature, the sensitivity is something like 95%. So there is a 5% chance that it will miss. And in fact, I ordered the ultrasound again, and the report came again the same, whereas the CT scan showed clearly the mass that he has. So people think, as you mentioned also, you described it very nicely, that you picture something and you know what's going on. But sometimes it's not like the picture that we have in our phones or in a camera. It's a different kind of picture that doesn't always show the reality. And it might show something that is not there, or miss something that is there. And this concept needs to be emphasized on more and more. So I really support this movement towards preventing overdiagnosis. And I'm glad that you have presented it, because I don't want people to miss such a wonderful presentation. It was really great.
Thank you. I want to add something to what you just said, which I think is really interesting. I think one of the things that doctors are not great at is taking account of the pretest probability. So when you examine that patient, you basically knew there was something there from the physical exam. The likelihood of an abnormality in the abdomen was very, very high. So that sensitivity of 95%, your likelihood after a negative test is still pretty high. And I agree with you that we don't teach Bayesian analysis very well, which is what that's an example of, and diagnostic reasoning, which is really the way, like what you illustrated in your example, is the importance of appropriate diagnostic reasoning and not just taking the test at face value. And it's such a critical skill.
Yeah, exactly. I didn't find questions in the Q&A, but I wonder if any of I have more questions, but I wonder if any of the audience would like to raise hands if they have questions.
I see a bunch in the Q&A.
Oh, really? I haven't
seen you don't see it?
No, I see only one, but that.
Oh, I see 11. Maybe it's, well, anyway, I'll go through them.
Okay, no, I can't see it. Oh, okay. I'm surprised. Yes, please go ahead.
There's one, the first one is from Abdul Rahim Abu Mustafa, who says, during the COVID pandemic, we learned to have plan B for our patients just in case he or she was unable to reach the urgent or the primary care. Patients are now able to screen themselves at home for COVID and many other diseases, and can use online calculators and applications to help in diagnosis. Do you think we should support this or keep recommending clinic visits? That's such an interesting question. And thank you for that question. My big picture answer is that I think those kinds of things like online calculators are really helpful. It does take a certain amount of sophistication, I think, for a patient to use them properly. And I think COVID's such a great example. Because a lot of the tests, a lot of the home tests, the antigen tests, and this changes every time we get a new variant, but are not particularly accurate in the first few days. And so I think they've done so much good, but they also, I think, can be difficult. Again, it gets to that Bayesian analysis. If the patient has a high likelihood of having COVID, then a negative test, they should still stay home and isolate. They should still assume they have COVID. And I think the online calculators are very helpful because they sometimes allow you to put in the community prevalence of COVID at that time, or even provide it. There's one from the CDC, and it's only US data though, that will, if you put in your zip code, it actually comes up with the COVID prevalence in your community right now to help you do test interpretation, which is really powerful. So I think in general, these things are really powerful and really helpful, both to clinicians and to patients directly, but they do take a certain amount of numeracy and sophistication. I think a lot of patients probably wouldn't be able to handle it on their own, but many could, and I think they're great. I don't know if people can respond. Do we have to unmute them? They're all muted, right?
Well, we have a comment in the chat, but I don't see Q&A. So if you see more questions, please go ahead. But I do, yeah. Something. Okay. Yeah.
So then Adnan Al-Wakayan, I deeply apologize if I'm butchering your names. I'm sorry. Asks, what is the interaction between overdiagnosis and the ethical principle of autonomy? For example, prostate cancer screening. Again, a great question. And this goes to what we can do about overdiagnosis. And so I thank you for asking that, because I probably should have mentioned this anyway. So the ethical principle of autonomy would suggest that the patient, should be able to choose to do things within reason regarding their own health. I think the key about overdiagnosis is really education. So if a man undergoes prostate cancer screening, it's important for him to understand what might come of it. So the fact that this might result in overdiagnosis and what that might mean for him. How would he feel about being labeled with this cancer? I mean, there are a lot of programs that try to follow men with early stage prostate cancer and not intervene so that we don't harm them. But what will that mean for this particular individual emotionally, for example? How does he feel like he would be able to handle that knowledge that he has, this cancer in him, and we're just going to follow it. We're not going to do anything. So I think that talking about it up front respects both autonomy and the reality of overdiagnosis and its potential harms, and is really the optimal thing to do. It's time consuming, and it can be difficult to do if you don't know the numbers. So if you have these conversations, often you sort of know different rates of things to give people numbers off the top of your head. But if you don't, it can be challenging, though there are decision aids that can facilitate these conversations. But I really think that talking about overdiagnosis, sort of lifting the veil on it, is the way forward.
Perfect.
All right.
I'm really sorry. So now you are.
Oh no, that's okay. I'll just go through them.
Somehow I didn't receive them.
Yeah, you're not seeing. It's weird. Okay, so then somebody else, I'm going to stop saying names because I know I'm just going to ruin them and I will feel terrible. So somebody else says, interesting topic. How would you avoid overdiagnosis? And I mean, I think I've sort of said this, you can't avoid it. You can try to minimize it and manage it appropriately. So the way to minimize it is to, avoid unnecessary imaging, particularly high-tech imaging like MRI and CT that we know pick up lots of incidental findings. I mean, there's a lot of literature on this. When you have incidental findings, I think it's also important to really be thoughtful about how you manage them. And that's at least a way to avoid harm from overdiagnosis. So to just follow something instead of intervening right away, and to follow it only for a short period of time. I see cases all the time where there's an incidental finding and somebody does a follow-up imaging test, which might be exactly the right thing to do, and then it's normal and stable, but they keep doing more follow-up imaging. Whereas, you can just say, done, we're done, enough. This is not growing. This is not anything to worry about. So I think making those hard calls helps. And then talking about overdiagnosis, talking about it with patients, particularly when screening, talking to them about overdiagnosis as a potential harm of screening and seeing how they would react to it, I think is very helpful. Okay, so here's a good question. How would you propose a clinician approach to the issue of overdiagnosis from screening, given that many practitioners are compelled to abide by guidelines in fear of prosecution? Really, prosecution? If they depart from normal guideline-driven care? Or is this issue only something that can be addressed by policymakers? I mean, I think it depends on your environment. If you're in an environment where you truly could get prosecuted for not doing a recommended screening test, then you sort of have to do it. I mean, the US is a pretty litigious environment. And the risk in the US is that I assume this is what you mean, the patient could sue you if you don't do something and you've missed it. And as you've missed a cancer or some abnormality. I do think, though, that if you talk to patients about the reasons to do something and the reasons maybe not to do it, you're protecting yourself against that to a large extent. I think that, I've had this experience many times because I tend to be a pretty minimalistic doctor, particularly by US standards. And I've had many conversations with patients where I talk about, okay, this would be the reason to screen, but here are the downsides. Would you really want to undergo surgery if we found an abnormality? How would you feel about being told that you have a cancer that may not affect your life? And people respond to that. And sometimes they're a person who definitely wants it all. And then, you go ahead and do it and inform them about overdiagnosis and how that could be a downside. but still go ahead with it. So I don't think there's a right answer, but I think, and this is kind of an unsatisfying answer, but talking to patients about it really is the only real option.
Yeah, communication is key.
Yeah. And it's not easy. And a lot of patients' reaction is like, well, like, you know, when something happens and they get diagnosed with something that it turns out to be nothing, like let's say an incidental finding that turns out to be nothing. What I find is that people's response to that, patient's response, is generally to be grateful, you know, gratitude that it turned out to be nothing, and not like, well, I never needed to know about that and go through that whole emotional roller coaster in the first place. So it can be tricky. Okay, so someone asks how you detect overdiagnosis, and I just want to say a word about that, because like I said, you don't know it except for in retrospect, you know, and or in the data. The way to detect it is like in the example I showed you about thyroid cancer, when you have really rising incidence of something, but no signs that it's harming people, that suggests that it's largely overdiagnosed. The overdiagnosis of breast cancer was detected in the randomized trials of breast cancer when you look at the number of diagnoses of, for example, like they'll look at the number of early stage cancers diagnosed in the screened group versus the unscreened, and the number of late stage cancers. So screening that detects all those early stage cancers being detected should prevent a late stage cancer. And to the extent that there's a difference in the number of early stage cancers between the group and the difference in the number of late stage cancers, you can sort of find overdiagnosis there. So you have to really look at it in large data sets. It's impossible to find. You just have to tell people that if we find something, it might represent overdiagnosis and we're never going to know.
And maybe, if I may add here, the power of systematic reviews as well, which is similar to, in a way, to large data sets, because sometimes people find an individual study, 3-4 studies that are showing benefit of an intervention, but when they do a systematic review of all the studies that have assessed the validity of this diagnostic or screening test, then the result would be different from those individual studies. And that's another concept in evidence-based diagnostics that has to be emphasized on, I guess.
Yeah, absolutely. All right, there are a couple more. Okay, so somebody says, we agree with the concept and nature of overdiagnosis. Do you have any recommendations on how to approach patients that come in requesting screening where in reality it does not affect mortality? That's difficult, and we certainly see this in the United States. You know, and I think sadly it depends a little bit on the patient and the context. I mean, I really educate people about why it's not helpful. And again, it takes time to really talk to people and explain why. You might think that this test will benefit you, but it won't. And here's why. And here are the downsides. I mean, I personally will not order things that I really think are unnecessary. I think some doctors do in order to kind of keep the peace and maintain the relationship with the patient. And you know, sometimes I don't think with screening as much, but sometimes with diagnostic testing, I find you get to a point where you just have to order a test because people are, you know, just the patient is panicking about something and you can't assuage their anxiety any other way. But again, I think just education, it can be difficult, especially in a place like the US where all the messaging that people see in the media is sort of all like about more stuff, you know, get more tests, get more imaging. And everybody has stories about like thinking that this CT scan saved their life. Even though, you know, I actually have an example. You know, I work in a cancer center where my minimalistic approach is a minority opinion for sure. We had a patient, and this was a terrible situation, but an example where I think it's an interesting example of not doing things and how difficult that can be. A young man who had had leukemia as a child, and he had total body irradiation, which puts people at risk for a million different complications and secondary cancers. And in particular, he had radiation to his brain. And he was now coming back in his early 20s and had these very non-specific complaints, like he was a little bit tired, and it was all very vague. And but he had a very aggressive mother who had gone through this cancer treatment with him as a child, and so is, you know, kind of traumatized by that whole thing, who kept interrupting him during the visits and calling the doctor directly and demanding a head CT and all these things. And the practitioner didn't do it. And then about 2 weeks later, he had much more severe symptoms and had a head CT and had a tumor, had a glioblastoma. And the lesson that the family took from that was that this doctor had missed something. And I think the challenge is that few weeks of not knowing about that brain tumor actually did not change his outcome. So I think, you know, even with the benefit of hindsight, I don't think she necessarily did the wrong thing, because he had such nonspecific symptoms, and it was so hard to wade through it with this, like, the mother and everybody making everybody else crazy. And it's impossible to tell that to the family. And this became this, like, the family was obviously they were very upset for many reasons, but this was a situation I was in the middle of because I supervised this more junior person, and, you know, trying to convince the family that she hadn't really, that missing it for 2 weeks didn't really change anything was an impossible task. And so that's the problem with not doing stuff, is you put yourself in these potential positions. So I don't have a great answer, but it's hard. These things are hard.
Yeah.
Okay, one more.
Yeah, exactly, because we're over time now.
Oh, are we over time? Oh, we should stop then. Should I do one more?
It's okay. We have a session at after half an hour. So the next session. So if you want to go on for 5 or 10 minutes, that's okay.
Okay, let me all right, let me take a couple of these. One person says, we tend to follow the U.S. Preventive Services Task Force for screening guidelines, and I agree it leads to overdiagnosis. Would you say we shouldn't use it on all patients or follow it blindly? I actually think the U.S. Preventive Services, like, you should never, guidelines are never for all patients, so you always have to individualize a little bit. The U.S. Preventive Services Task Force is relatively conservative, at least by U.S. standards, and their guidance tends to be pretty similar to other countries, unlike other guidelines in the United States that tend to be actually much more maximalist and aggressive. So I think that I tend to follow their guidelines as well. They're very evidence-based, they're very rigorous. And they actually have been criticized for building a lot of shared decision-making into their guidelines. Like, people say, well, that doesn't help me know what to do. So I mean, I think at the end of the day, those are good ones to follow, although no guideline can ever apply to all patients. All right. What is missing? Oh, this is a great question that there's no answer for. What is missing in teaching, training, and practice in the medical field that results in overdiagnosis? I don't think there's anything that's missing that results in overdiagnosis, because overdiagnosis is going to happen whenever we test people for anything to some extent. But I do think that one of the big, oh, they can't write questions anymore, probably because it's afternoon and the session's over, maybe. Anyway, I think that's probably, oh, what was I saying? Okay. I think the thing that's missing is the understanding of diagnostic reasoning that helps minimize all these problems and really optimize testing and optimize understanding of how to interpret tests, which helps, you know, manage overdiagnosis and reduce unnecessary care. I've been involved in a couple of recent research projects around this, and what we found is that, yeah, I mean, overtreatment, somebody just said, overtreatment is also a really important component and a result of overdiagnosis. But we've done a couple of studies of clinicians' understanding of diagnostic reasoning in terms of taking a pretest probability, applying like sensitivity and specificity, like Dr. Al-Ansary said before, and clinicians are terrible at it. And I don't think this is a US specific problem. I think this is probably everywhere, although our study was done in the United States, but people are just terrible at it. And we need to figure out a way to increase that understanding. And I don't know what the answer is. We're actually developing a game to try to help people intuit these things better. And I think, you know, games are a great way to teach things like this that require just kind of repetition. But, you know, medicine attracts a lot of people who are interested in biology and not math. Like, as you know, Lubna said in the intro, I'm a math person. I studied math at university, and I think very intuitively this way, but a lot of doctors don't. Like, these are people who come from a biology background, and it's hard to teach these quantitative kinds of skills to doctors. And I don't know what the answer is, but it's a challenge. So maybe I'll stop there.
Yeah, it has been fantastic. I've enjoyed it very much, and I'm sure that the audience did. And it's clear from the interaction with you and having even more questions that I can see. But I mean, this is the opening, and maybe we are going to have more and more sessions with you in the future. I would encourage them to sign up for the webinars of preventing overdiagnosis that is being carried out by, I don't know by whom, but I'll find out something Scottish, I think, or.
Oh, I don't know where the next one. I don't know where the next one is.
Yeah, okay.
Yeah, that's a great.
So
also, you know, Lubna, this is my last day at work at Sloan Kettering, which I didn't go into, but you have my Gmail address, which people, if you want to, you know, if people want to ask me, I'm happy to email.
Perfect. That's really fantastic. So thank you very much.
All right. Thank you. And thanks everybody for
that's the
attending.
Beginning of something new and among all EBMers and in our region in particular. So thank you very much.
Great. Thank you all.